Welcome for the second session. It's my pleasure to introduce Dr. Ed Engleman, professor of pathology and expert in immunotherapy and the interaction of tumor cells with the immune system, most recently showing this fascinating modulation of tolerance and enabling of metastasis in lymph nodes by tumor cells. So really excited to hear your talk here today.
Well, thank you so much. It's really an honor for me to be here celebrating my colleague, Professor Barrick. I'm an immunologist and not an expert on ovarian cancer, but I hope you enjoy our recent discovery, which is quite exciting. Before I get started, I want to disclose that a new company was formed based on discoveries made here at Stanford. ImmuneEdge licensed our technology and hoping to develop new treatments for cancer and other diseases. So, for those of you that are not immunologists, and I suspect that's most of you, I have been, I would say, somewhere between obsessed and constantly thinking about why is it that in certain circumstances, the immune system selectively fails to respond. We call this acquired immune tolerance. It's an active state wherein the adaptive immune system, principally our T cells, selectively fail to respond to antigens that should stimulate a response. Such tolerance is very important in preventing autoimmune disease, and perhaps a classic example would be maternal fetal tolerance. Have you ever thought of why is it that children get born when in fact all fetuses are allogeneic? And indeed, once your children grow up, if they want to donate an organ to their mothers would ordinarily reject those organs unless placed on powerful immunosuppressive drugs. Yet, during pregnancy, there's a message that the mother's immune system receives that says, don't attack. And without this mechanism, we would not have a human race, we would not have mice or rabbits. So it's remarkable, and yet the mechanism has not until now been discovered. Cancer, unfortunately, very smart, hijacks this mechanism. And one of the main reasons, not the only reason, that cancers evade our immune system is because of tumor-induced immune tolerance. Now think about that. Every cancer has mutations resulting in the creation of foreign proteins that should be recognized. Obviously, some tumors have more than others. And yet, as a rule, the host fails to reject the cancer because of immune tolerance. As I mentioned, the mechanism for this acquired immune tolerance is not yet defined. I hope that our findings will clarify that. So I don't have time today to go into all the reasons why we and how we went about trying to identify this mechanism. It's been many years, but we decided to pursue a system of induced immune tolerance by a type of radiation developed at Stanford 50 years ago for the treatment of lymph node cancers, Hodgkin's lymphoma, by Henry Kaplan, called total lymphoid irradiation, or TLI. When TLI is administered to a mouse or a human in combination with bone marrow from the organ donor, and then that's followed by an organ transplant, the recipient does not require any immunosuppressive drugs because immune tolerance is induced. Now, my colleague, unfortunately deceased colleague, Sam Strober, championed this idea, and he and his colleagues developed this approach for the induction of tolerance to transplanted organs. The kidney transplant data is very encouraging, not yet FDA approved, but very encouraging. And in mice, when we do this, we can transplant any organ from any strain of mouse to another recipient strain using this approach. So we decided to use this system to try to nail down the mechanism of inducible immune tolerance. Now, with the knowledge that the tolerance is antigen specific and is believed to be mediated by antigen specific Tregs. Our assumption was that, like any T cell, these antigen specific Tregs would need to be activated by an antigen presenting cell. The way our immune responses are generated, antigen presenting cells such as dendritic cells, maybe macrophages, take up whole cells, process them, and then present those antigens to T cells. Ordinarily, most of us are familiar with the idea this is how we induce an active T cell response, a CD8 killer response, a CD4 helper response, but also Tregs. Even though our understanding of how antigen-specific Tregs are induced is rather limited, our assumption was that acquired immune tolerance must be started at the level of an antigen-presenting cell, processing antigens and presenting them to initiate an antigen-specific Treg response. So, again, working on this model system in mice, where the mice have been treated with TLI and received bone marrow and an organ, in this case, a cardiac transplant from a donor strain, completely unrelated strain. And normally this works, but if we selectively delete the type 1 dendritic cells, it doesn't work. So now we've proven this hypothesis that, excuse me, that antigen presentation is a requirement. Now, our assumption is that this is the initiating event. We didn't know for sure, but Sangwei Zhang, a longstanding scientist in my lab, then took the next step, which was to profile the genes before and after the induction of tolerance using TLI. So she isolated the type 1 dendritic cells before treatment and after treatment and the sites of radiation and did classic gene expression profiling. And the shock that occurred, and I required that she repeat this experiment 5 times because I didn't believe it, was that the most upregulated gene in the antigen-presenting cells was the receptor for erythropoietin, or EPO. Wait a minute, how is that possible? EPO is a hormone that makes red cells in blood and bone marrow. Is it possible that EPO could have a second, very fundamental function? Well, I'm here to tell you, yes. I think it's more fundamental than its red blood cell function. Simultaneously, Sangwei found that the levels of EPO skyrocketed when the radiation was given. So this gene encoding the EPO receptor looked really interesting because it was upregulated thousands of fold. Well, then what Sangwei did, and it took almost 2 years, she created mice that were missing only the EPO receptor from the type 1 dendritic cells. You can do that in mice, can't do that in human beings. And what she found is that in the absence of the EPO receptor on antigen-presenting cells, you could not induce tolerance. And that was it. That started, I was obviously incredibly excited about this. Then further studies showed that the mechanism by which this works is that the EPO receptor, once activated by EPO on these cells, enables these cells to take up whole cells, typically dying cells or dead cells, process the antigens, and then induce antigen-specific Tregs. This is the mechanism by which antigen-specific Tregs are induced. And she showed in the model that the alloantigens, in this case, from the donor organ, were the responsible for the induction, taking up of those cells, and ultimately the antigen-specific Tregs mediated the tolerance and specifically suppressed the rejection of the organ. Okay, sounds good, but then what about other situations where we need tolerance? What about spontaneous tolerance? Hold on, sorry. Always turn off your cell phone before. Anyway, in data that we have not yet published, Guotao Yu, a member of the lab working with Songwei, has shown again in mice, because we do all these studies in mice, that if you do the same things, if it turns out that the placenta in pregnancy makes lots of EPO. That's been known for years, never explained. And it turns out that the maternal type 1 dendritic cells express the receptor for EPO-R. If we block it or remove it, we get fetal absorption, no births. So this is the mechanism, or at least a critical component of maternal fetal tolerance. Incredibly exciting. But what about cancer? We're here today to talk about ovarian cancer. Does cancer rely on the same EPO-R mechanism to avoid immune attack? So another member of my lab, David Chu, who is a postdoc, now a staff scientist, decided to explore this, starting with hepatocellular carcinoma. Why liver cancer? Well, it turns out that he looked in the public databases. In fact, you can find this for a lot of cancers, including ovarian cancer. But David started with liver cancer because he had already, during his graduate student years, developed models of liver cancer that are very powerful and mimic human liver cancer. And what he found when he looked at the public databases is that, in fact, patients who had high levels of EPO expression in their tumors had worse clinical courses, and those that had lower levels had obviously better clinical courses. In addition, this was associated with immunosuppressive macrophages and an increase in Tregs. So he then went on to test in these animal models directly whether or not EPO and EPO-R were playing these roles. And this work is published in Science about 3 months ago, so you can read the details. But the bottom line is the tumor cells themselves produce EPO. Many tumor types, including ovarian cancer, produce EPO. But this was his discovery: produce EPO, that causes macrophages to create a cold tumor environment by eliminating or preventing T cell activation other than Tregs. And if we remove the EPO or the EPO receptor from the macrophages, in this case, macrophage-rich tumor, we can create a hot tumor and tumor regression. I don't have time to go through all the details here, but he proved this in many different examples by creating tumors that either produced or didn't produce EPO, by blocking the EPO receptor or removing it, and showing that this had a profound effect on tumors, not only in terms of their tumor cell, the immune cell infiltration, but also in the response of the tumor cells and the content. As I mentioned, in the case of many tumors, the main EPO-R expressing cell is the macrophage, not the DCs. However, we obviously have to deal with both subtypes. And this is true in mouse liver cancer and human liver cancer. And these are the cells that express the receptor. These are the cells that are controlling the immune response. Now, obviously, we're very interested in immunotherapy. What happens if you remove the EPO receptor? And what is shown here on the right is we're dealing with tumors that are completely resistant to checkpoint, to PD-1, anti-PD-1. As you can see, in the absence of EPO-R, there's tumor regression, but majority of the cancers are not cured. If we now add anti-PD-1, all the tumors are cured, whereas anti-PD-1 on its own had virtually no effect. Let's move quickly now to ovarian cancer, where my colleagues, Oliver Dorigo and Aaron Rankin, are collaborating with us. And what they have found already is that high-grade serous carcinoma of the ovary produces EPO and contains lots of EPO-R positive macrophages. Furthermore, when they used our are mice that are missing EPO-R, in this case selectively in macrophages, the tumor that is a mouse tumor that is considered to be the best model of HGSC almost doesn't grow at all. You can see the suppression of tumor growth is about 90%. Very exciting. This reduced metastatic burden and the absence of EPO-R on macrophages is mediated by T cells. You can see the CD8 T cells come up. If you eliminate them, you do not get this beneficial effect. Very exciting. So what can I tell you in terms of summarizing? The way this works is that antigen-presenting cells take up antigens, and they usually do this in the context of whole cells, dead cells, dying cells. And if EPO is present in sufficient amounts and EPO-R is expressed, you shift from an immunostimulatory response to an tolerant or immunosuppressive response, and the tolerogenic APCs induce antigen-specific Tregs that then block the activation of CD8 T cells while inducing tolerance. Obviously, we want to prevent that. Please note that anti-PD-1 works at the other end of the response after T cells have been activated. So you can imagine why this approach of dealing with EPO and EPO-R could be highly synergistic with anti-PD-1. Now, I got to tell you some stories if I have a little bit of time to do so. How long has it been known that EPO might accelerate cancer? How about 20 years? So, as some of you may know, recombinant EPO was produced originally, I guess, by Amgen. It's the basis for Amgen's success. Also, Johnson & Johnson. Years ago, the peak sales of EPO for treating chronic anemia were over $10 billion a year. And then, as studies were done in patients with cancer who were anemic and treated with EPO, recombinant EPO, studies started to appear that the cancer got worse. And eventually the FDA issued a black box warning. We're not allowed to use EPO for the treatment of anemia and cancer unless the patient has no hope of recovery or cure. And that black box warning has been in effect for almost 20 years. And yet, despite this, why wasn't this function of EPO identified? Well, I can tell you because the age of immunology and immunotherapy for cancer came a few years later. I myself talked about the potential, as we were talking about earlier today. I was giving a talk on potential for immunotherapy in cancer about 12, 15 years ago, and a very prominent colleague on the faculty asked me, why am I wasting my time studying the immune system in cancer? Because everybody knows that cancer is caused by mutations, causes cells to proliferate. What does that have to do with the immune system? Well, now we know that the immune system is playing a critical role in enabling cancers to survive and grow. I believe the mechanism we've described is an important one and hopefully will turn out to be a useful target for therapy. But to summarize my comments today, tumor-derived EPO interacting with its receptor on antigen-presenting cells in the tumor promotes a cold, T-cell-deprived microenvironment. Blocking or removing the receptor on the antigen-presenting cells breaks this tolerance, resulting in the transformation of cold tumors into hot ones that are now sensitive to immune checkpoint blockade. We have a lot of descriptive data suggesting that human cancers behave the same as our mice, but I would caution we have not yet developed drugs to test this hypothesis in the clinic. That will happen. In the next several years, we'll know how useful this approach will be, but right now it's just an exciting discovery of how the immune system is regulated at its most fundamental levels. So again, to summarize, peripheral immune tolerance or inducible immune tolerance is an active state wherein antigens that should stimulate a T cell response do not do so. Activation of the EPO receptor on antigen-presenting cells by EPO, and efferocytosis, which means the uptake or phagocytosis of dying dead cells. Results in immune tolerance to alloantigens and tumor antigens. I suspect certain infectious agents as well. Blocking or removing the receptor on antigen-presenting cells breaks tolerance, resulting in rejection of allografts, fetuses, and hopefully tumors. So with that, I'd just like to acknowledge my fortune in having a lab full of enthusiastic trainees. This particular photograph, my lab is about half this size, but every summer for the last 20 years or 25 years, I've accepted up to 10 high school students in the lab to serve as summer interns. I don't pay them, but it's an extraordinary experience. And this is the group from this past summer. But I want to highlight the contributions of Sangui Zhang, who's not here today, who's been a colleague and lab member for more than a decade, and her important discovery. David Chu, who's been in the lab now for almost 5 years as a postdoc, and who led these efforts. And then on the right side are some of our collaborators. And of course, here today, I want to specifically identify Aaron and Oliver and Aaron's student, Natalie, who were working with us collaboratively to try to see if this is going to be important in ovarian cancer. So with that, I'll thank you, and I'm done. Thank you. I forgot to mention that, as I mentioned, the liver cancer work was published in Science at the end of April. Our Nature paper, which describes the fundamental genetics, was just accepted this morning at 7 in the morning. So I'm thrilled about that. Yeah.
Congratulations.